out the rest is most. So, you know, you bring up an excellent point. I think working with adolescents, you need a different approach than just trying to do the same old thing that we've done with adults for all these years.
We have time for just one more question.
Can you imagine any circumstance under which you would terminate treatment with somebody using an abstinence, using a harm reduction kind of approach?
Well, if I thought that they had totally resolved the problem and they were out of the woods, then I don't feel that I would have to continue to see the person. But I'm not going to let people down in the middle. No, I'm not going to say, and I know some therapists do this, you know, if you continue to use, I'm not going to see you. Okay, well, what are they going to do? They're going to see somebody else? Okay, maybe. Or at some point they're going to go, these damn therapists are not helping me at all, you know. And but you don't want to coddle, enable, and, you know, not deal with the issues when they come and deal with the crisis of and the danger that they're in. But I still want to be there for them. I'm not going to lock them out.
Well, are there any final comments that you might care to make?
I would say harm reduction, it's new. People are saying maybe they should give it a different name because it's sort of, people have a knee-jerk reaction to it. Mm. So that's why these terms like recovery, readiness, and things have been discussed by people in more traditional programs as a way of trying to fit it in. Mm-hmm. But I think, you know, it's a new approach that's needed just because there was sort of a big gap there. There was really nothing for people who were continuing to use unless they were able to somehow fit themselves into traditional treatment. Or we locked them up, but of course that doesn't help because they can get drugs in jail just as easily or maybe more easily than on the outside. So I think, you know, we're finally getting to the point where we have to ask, isn't there some other way that we could go in addition to what we've already been doing? And I think that's where harm reduction comes in.
Well, thank you for your refreshing and sensible ideas.
Thank you.
Hi, welcome to our program on addictions. Today we're going to be discussing the harm reduction model with our guest, Dr. Alan Marlott. Judy, what contributions has this approach been making to the field of addictions, this harm reduction model?
I think it's bringing some very sorely needed flexibility to the array of treatment options. You know, in theory, we all want to take our clients from where they are. We want to meet them at the place where they are in their problem behavior. But in reality, most of the treatment programs are able to help somebody who is ready for abstinence right now. But for other people, the options just don't seem to be there. With harm reduction, they are.
It seems like such a great option because the other programs seem to demand that you have to be better before you can get treatment.
Yeah.
And this model seems to allow a normal progression in stages to take one to a place of abstinence, or at least a life of addictions where it's not a problem for others.
And I think that with the harm reduction, you can work with somebody who is still using, but try to help them avoid some really severe life-threatening difficulties. That's the way I see it.
Now, let's bring out Alan Marlott and find out some more about this approach. Welcome.
Thank you.
Oh. Alan, could we start out with just asking you to tell us, what is harm reduction? What do you mean by that?
Well, you know, it's sort of in some ways self-explanatory in that harm reduction is programs which could be working with individuals, it could be policies, it could be environmental changes designed to reduce the harmful consequences of using substances, drugs, but also alcohol, cigarettes, could be legal or illegal drugs. So the goal shifts a little bit from, is this person an alcoholic or an addict, or sort of looking at the diagnosis of the user, but looking at the consequences. What's happening as a result of this using of substances? What kinds of harmful consequences are there? And what can we do to reduce it? And of course, abstinence would be an ideal goal because it tends to be the lowest risk, and it's sort of on one end of the continuum. But for many people, abstinence is not something that they can attain right away, or they're unwilling to consider it. And yet they're putting themselves and other people's behavior at risk. For example, sharing needles for intravenous drug users can obviously increase the risk of transmission of HIV. And so actually harm reduction started in countries like in the Netherlands around issues about the link between drug use and HIV, and what could we do to reduce the harmful consequences for people who, even though they're still actively injecting drugs. So that would be probably the first big example of harm reduction that we're all familiar with.
How does this approach conceptualize the addiction process?
It looks at addiction more on a continuum basis, rather, let's say the disease model tends to be dichotomous. You have the disease or you don't. And in the harm reduction model, they look at the problems that it's causing on a continuum, from mild problems to very severe problems. Not just for the individual, but for their environment, their community, their family. So then once you look at it that way, your goal seems clear, is to move down step by step the harmful consequences so that you can begin to make changes. Because the option is not doing anything.
Yeah.
Person either goes into abstinence-based treatment, which we would all prefer, or what happens if they don't. And we know that 80% of people with alcohol and drug problems in this country are not in treatment, and they're unlikely to go to treatment as it's currently set up. The harm reduction idea is, let's lower the threshold, let's not make abstinence necessarily the ticket to get into treatment, but more the distal goal. The proximal goal is getting somebody to take some steps right away, because otherwise they are really left doing nothing. So the harm reduction is a middle ground, but it's trying to move people more into getting more help.
And you start with where they're at.
You start, yes. The thing is to start where people are at and partner with them. And I think the word partnership is important in harm reduction. Because, like, for example, when the needle exchange programs were first started in the Netherlands, who started them? It was active drug users. They went to the government and said, look, you're not allowing needles to be purchased legally, and we're all sharing needles, and now it turns out the HIV virus is being spread this way. Can't we change the policy? And the government and the public health officials responded, and they, through their partnership, working together, they came out with a program that saved a lot of lives. So even in individual therapy, there's more of client-centered therapy. I mean, this is not new to many therapists, because often therapists operate that way anyway. You know, let's meet the person where they are rather than where you think they should be. Partner with them and sort of work together to make some changes. That's different than a top-down.
Alan, would it be going
approach.
too far to say that with the treatment programs, in effect, we withhold treatment for people who aren't ready to be where we think they should be?
Well, if somebody's not willing to be abstinent in many programs, they will be kicked out. In fact, I was just at a treatment conference for an inpatient program for Native American adolescents in Seattle, where they had were staffing this one young guy who had had a lot of problems with cocaine and alcohol, but was making good progress in the program, seemed to be getting some real help from it, and they let him go home on a weekend pass, and came back Monday morning, and he reported to his group that he'd had a near miss. In other words, what happened, he went home and his brother offered him a marijuana cigarette, and he wanted to please his brother or whatever. He took 2 tokes of the cigarette. Then he realized it's going to make him want cocaine, puts out the cigarette, comes in and he tells the group that he had pulled out of what was going to be. But then the director said, but you did smoke 2 tokes of the cigarettes, yes, of the marijuana cigarette. Guy says, yes. You know the rules. They discharge him. You know, and my students were saying, oh, what's going to happen to this guy now? And, you know, that was a good question. But the director said, we can't have any drug use in the program because that's, you know, we have our regulations, we have our rules. And it's strange, you know, because they're told that this is an addictive disease and that they can't control use, and then when they do it, they get punished for it.
Yeah.
And that doesn't happen all the time, but it still happens in lots of places.
Can you talk about the therapy process and some of the goals that go on in therapy using a harm reduction model? You told us that it begins with there's a lot of empathy, a lot of acceptance.
Yes, you want to try and work with the person and find out what are the problems, but you also want to ask the person what they like about whatever they're doing. What are the pros and the cons, so that you can get a sort of a balanced perspective. And then once you've got the person to recognize that there are some problems, it's sort of easy to motivate them to reduce the problems, because those are the things that they see as problems as well. And so it's an assessment of what the problems are, and then often choosing what they think they could do first. So it's a kind of like a behavioral shaping thing, you know. What is something that you think you could accomplish in terms of a first step here?
So it's really tailored to each client. Tailored
to the client, because you may be interested in changing the method of drug administration. In other words, if a person is still using IV drugs, is there some chance that they could switch the method of administration to snorting, because you're not same risk of HIV drops, or going to methadone or something like that, which would be less risky. So it would depend on what the particular problems are, and often there are associated mental health problems as well. And you can, the harm reduction therapy approach tries to integrate the drug problem and the mental health problems to see, is this person, you know, self-medicating certain kinds of problems, or is the use of the substance exacerbating the depression instead of making them feel better, and trying to give them a unified model so that they can begin to realize that the steps that they're taking are beneficial for both kinds of problems.
It seems as though in that relationship with the client really has a lot more opportunity to be honest in his or her interaction with the therapist. You're not insisting that the person self-identify the addiction as the single cause of all their problems, but you're letting them look at their lives as though they're the experts.
That's exactly right. A broader lifestyle approach. For example, addiction programs are now realizing that if they measure their success only in terms of abstinence rates, they're not looking that great, because we all know that on the average 1 year after treatment, the relapse rates are 70 to 80%. So if you start to look at other areas, things like the Addiction Severity